So I'd like to, at this point, invite Dr. Drakos to come up and speak. He's going to talk about shock team, organization outcomes, cost effectiveness, and applicability in large regions. Dr. Drakos is from the University of Utah.
Thank you. Thank you to the organizing committee for the invitation. We're going to talk about all these things within 8 minutes, so we should get started. These are mountains, and we'll talk about the area, this is the Salt Lake Valley, and the area beyond, well beyond the Salt Lake Valley that this refers. So we're going to divide the talk into the why, who, when, and how, and some data on the feasibility and efficacy. So why? Why it makes sense? So one of the first points that many of us in the field kept talking about the shock team more than a decade ago, more than 15 years ago, is that this is a complex thing to deal one person in the middle of the night, and difficult thing. And this slide is out of the scope to go in detail. It's just to make the point that there are several things that may be going wrong when you have a patient with shock. And then the types of ventricular failure, these images are not moving on purpose because they don't need to move to make the point. So this is a patient with shock, probably it's an acute on chronic. You can see the dilation. This is another patient on shock, and the problem here is different. The problem is on the right side. And this is another patient, again with shock, and now the problem is that the heart cannot feel. And so all these people are in shock, and all these things can be happening. Then we are cardiologists, cardiocentric, not all of us here, but many of us, and we need to think about outside the cardiovascular system when it comes to shock. So it's complicated, right? We need to think about the lungs, we need to think about the kidney, and all of the instruments we have in order to help. And then when it comes to ways to help restore the circulatory the flow, right, with circulatory support. I'm going to go quickly. This is for the left ventricular failure percutaneous options. Then we have all these for the right ventricular percutaneous options. Then we have the surgical options. I mean, this is complicated. And then when it gets to the patient and try to put everything together, there's a lot of variability coming in, the age, the comorbidities. We never have psychosocial issues, right? And then the exit strategy is also something that it's complicating the situation even further. So after the complexity of the case, I mean, we do have favorable experience with other teams in our institutions, as you can see some examples there. So this adds to the rationale. And then when you try to think, what guidance can you get in order to deal with these complicated things? As you can see there, it's all level of evidence C mostly. So we don't really have good guidance. So all these are kind of reasons why shock team makes sense. So who, when, and how? What would be the goals? Of course, to rapidly identify what is the problem and the famous root cause analysis. If we can have identification of the root cause, we can go after it, right? Mariel showed earlier that on top of the supportive therapies, I mean, level of evidence of high significance, I mean, we have on the revascularization if we have an acute MI. That's it. And then it's an important issue when to escalate, but a very, very difficult issue when to withdraw, especially in a young patient in the middle of the night by yourself. So all these are reasons why the shock team really can be helpful. So the core members vary by institution, right? Not everybody has all these specialties on call. We learned the hard way that nursing needs to be integral part. In our first version of our shock team, when we started, it was not, and we learned that this is very important. We all know who is on the bedside. This is a paper that Jason Katz led, and I had the honor to participate, that just came out a few days ago in the Journal of the American Heart Association, where we talk about all of the people and the players that can comprise a shock team. And I'm going to share with you very quickly our shock team algorithm. And when we started doing it in a room with all of the specialties involved, we debated whether we should have specific criteria or not. And in order to keep it simple, as we know when it's not simple, it's not going to happen, we elected not to have specific criteria. Anybody who smells bad, heart rate is up, and the blood pressure may not be up yet, low, or vice versa. It's just a call. It's just a discussion. Nobody's running from home like a STEMI. So this is our members that they get paged. And then the only decision node in our algorithm is this a STEMI or a not STEMI. So if it's not a STEMI, including the acute coronary syndromes with non-NST elevation, then the algorithm is there. Right heart cath, leave the swan in, And then left heart cath, if we have the criteria you see in the blue box, which is the classic shock definition from all the trials, we consider MCS. We say consider because, as we know, it's not proven. And so we leave it on the discretion of the team where temporary MCS makes sense. And then possible left heart cath depending on the scenario. And then if it's a STEMI, the compromise is that because time is muscle, until the door to unloading comes out and we learn something different. The compromise to the interventional cardiologists who want to do a cath immediately is because we need some hemodynamic information. We use the access for the cath in order to get an LVDP, so we can inform the blue box there. We cannot have the invasive hemodynamics, make the decision if we need or not temporary MCS, and then simultaneously with the MCS, or sometimes even before or after, depending on the scenario, the PCI. And then we can do the right heart cath later. Some data. So the bar is high. And you've seen data today why the bar is high. And this is our shock team that was published in Circulation about the same time, the Innova group, and I show you published the paper in JACC. These were the first two shock teams. We just got the first 120 people that we started following after the shock team was established, and we compared them with the 120 people before. You can see there they were well balanced, not randomized, but well balanced, the two groups. And one of the issues when we were debating and discussing this was, oh my God, too many cooks in this situation here, maybe delays, disagreement, at least in our hands, and the shock to support time is one of the decisions. It didn't cause delays. And now this is the results that we published. And you could see the difference. And the shock team in Innova published their experience about the same time in JACC. They had similar results. Again, non-randomized, but showing the benefit between the shock team approach and not. And then the Canadian group from the University of Ottawa about the same time also published their experience. Now, this is the difference they found, similar to the other two groups. The CCCTN network also published this paper with larger number of patients, and as you can see there was a mortality benefit in the group of hospitals that they had a shock team. Now, we just presented in AHA some data on the cost effectiveness, given that a lot of people are saying we'll have all these people involved now, cost will go up, everybody will bill for consults. And so as you can see there, in our analysis, and this is under review now, we showed cost effectiveness. This is, again, the paper that just came out about the shock teams, where the three first institutions that they started shock teams, they are sharing the lessons learned. And this is going to be the segue to what I have there with the red box, which is the examination of the virtual options. This is our area, and you can appreciate it's a very large area, more than 15% of the continental area of the country. And we get patients from everywhere, all the way from Alaska to Dallas, due to our VA system as well. And this is a paper we have now examining what drives these outcomes out of more than 1,100 consecutive patients. And we don't have the time to go analyze everything, but a big proportion of those were transferred from very far away. And you can see in the multivariate predictors of native heart survival that some of these modifiable predictors, and this is consistent with what Alex Mebaza just published in Journal of Cardiac Failure, like the shorter length stay at the spoke and the shorter time to implement temporary MCS, which came up as modifiable predictors of good outcome, are things that the virtual shock team, right? Because not everybody in these smaller peripheral hospitals have all these abilities and the team members to be on call all the time. So a virtual collaborative shock team makes sense. This is the summary slide. Again, the paper that just came out in JAHA, where we try to put everything together. These are patients, and I'm just going to leave these for the discussion, which is out of our think tank, some of the issues that they are being debated and discussed right now in this space. Thank you.
That was outstanding, and we have a couple minutes. So, Jim, why don't we comments or thoughts?
Well, one comment about some of the last discussions, and it sort of feeds into this as well, is we can talk about all of what we do in our own hospitals, and we can talk about how we help our outside hospitals. One of the things that I've come to realize as I've been working over the past couple of months in my institution is that whenever we budget for a new hospital or a new connection, nobody budgets for an EMS or transport system. I mean, some hospitals we have 4 helicopters, 3 may be flying at one time. We have 2 buses that are critical care, but going a long distance. So I do realize we can put impellers and balloon pumps at our outside hospitals to stabilize the patients, or one of the hospitals can put them on ECMO to transfer them to the hub. But getting those patients into a bus efficiently, getting them moved efficiently is a whole other that we don't really talk about that much in all of our other, we draw little ambulances on the algorithms, but nobody talks about how do we operationalize those.
And I couldn't agree more. And to add to this, who should be in this helicopter or in this plane? And do you need to have a bunch of people there and all these specialties? So we just published something that even ECMO patients can be transferred with a good nurse. I mean, nurses are great, as you know. And you don't need to have all the time all these people involved in order to reduce the cost and make it more feasible.
Just getting them into the ambulances, sizing the ambulance, sizing the plane for ECMO. Most of them will be on ECMO and impeller or ECMO and a balloon pump. They don't make those devices small enough to just load into helicopters sometimes. It can be very difficult. But I think we all face the same problem.
Dan, comments?
Not really any comments about this.
We're going to let you comment in a minute.
Yeah, I think it's multiple studies are just showing shock team. More heads are better than one. More cooks make a better dish.
One thing that people bring up, this issue about having patients transfer, and I can tell you in multiple sites have shown that you can safely transfer cardiogenic shock places to a center of excellence. But you have to do the work ahead of time to get all this stuff set up. So congratulations, you guys have done a great job to kind of really set this for the whole United States.
I mean, what we say that a bad thing sometimes comes with good, the COVID era helped this collaborative approach and the virtual shock teams formations and everything, because we were forced during the COVID era to leave the patients there and collaborate with them even more. And we saw the pros and the cons of what is delaying and not delaying. And I think another thing that we learned from the COVID era is that the virtual relationships can still be meaningful if you cultivate them. And I think that's the field is ready right now to expand this.